How do we determine blood pressures in pediatric patients? It's fairly simple with this equation. Let me show you. Okay, so when it comes to blood pressures in pediatrics, there's two things that you can remember. First off, 90 plus 2 times
babies. Really, we're going to be talking about the mean blood pressures. The mean, like the name suggests, is the average blood pressure. Since we spend a lot more time in diastole than systole, generally the mean blood pressure is closer to the diastolic blood pressure than the systolic blood pressure. Studies on healthy term babies have shown that the mean blood pressure in the first few hours to the first few days of life of healthy term babies is somewhere between 50 and 60. In healthy term kids and older kids and adults, it's much easier to define hypo and hypertension because you can just collect data on healthy normals. And then if the average blood pressure is 2 standard deviations less than the mean, then that person has hypotension. And if the blood pressure is 2 standard deviations above the mean, then that patient has hypertension. The problem with preterm babies is that they're not really normal. By definition, infants are not supposed to be born less than 40 weeks or less than 37 weeks, which is full term. So what should we consider normal for a 26-weeker? What if they need a little bit of oxygen, or they need to be on the ventilator machine, or they are not tolerating feeds? Could that still be considered a normal situation with a normal blood pressure? Because of that, we don't have great normal values for preemie babies, so we can't calculate 2 standard deviations less or more than the averages. We do know to have the wrong cuff size for a premature infant with their tiny limbs. Generally, the cuff pressures slightly overestimate the actual intra-arterial pressures. So when we say intra-arterial, we mean the monitoring by like a umbilical arterial catheter or a peripheral arterial line, so a PAL or a UAC. Even those lines, the waves can get dampened, especially if they're tiny arterial lines on like tiny little babies. There could be a clot in it. It might just not be picking up in that particular vessel. So we
infant with the focal convulsion in the right side. He was normal and just bottle fed. What do you find clinically? Retinal hemorrhage. Baby. Okay, infant with focal convulsion in right side. He was normal and just bottle fed. What do you find clinically? Retinal hemorrhage secondary. The most common manifestation of neonatal meningitis. The most common manifestation of neonatal meningitis is irritability. Scenario of a child with convulsion. Tonic-clonic, temperature 38. Scenario of a child with convulsion. Tonic-clonic, the temperature is 38. So symptomatic status, repeat, epilepticus, because there is fever and the convulsion is tonic-clonic, symptomatic status epilepticus. If it lasts more than 5 minutes. Patient with status epilepticus that is not common type. Not common type in children is cryptogenic. Not common type in children is cryptogenic. Baby has history of fever, presented with convulsion for 40 minutes with fever. Subtype of epilepsy not included. Baby has history of fever, presented with convulsion for 40 minutes with fever. Subtype of epilepsy not included means the cause is not included. If you don't know the cause, it is cryptogenic. Don't know the cause, it is cryptogenic. Cryptogenic epilepsy. What is cryptogenic epilepsy? This is when the cause of the person's epilepsy has not yet been found. If you don't know, means the subtype of epilepsy is not included. That means if you don't know the cause of the epilepsy, then it is called cryptogenic epilepsy. If you don't know the cause of epilepsy, then it is called cryptogenic epilepsy. Then symptomatic epilepsy. Epilepsy is called symptomatic when there is known cause. This may include whether it is from head injury, whether an infection like meningitis or brain not developing properly, a stroke, a scar, or a tumor. If you know the cause, then it is called symptomatic epilepsy. If you don't know the cause, then it is called cryptogenic epilepsy. Then idiopathic epilepsy. Epilepsy is called idiopathic when it is thought to be due to a genetic tendency which could have been inherited from one or both the parents, or due to a change that happens in the person's genes before they are born. It is called idiopathic epilepsy if it is related to genetic. Epilepsy is called idiopathic epilepsy if it is related to genetic. For example, epilepsy is idiopathic when it is thought to be due to genetic tendency, which could have been inherited from one or both the parents, or due to change that happens in person's genes before they are born. So genetic causes is usually idiopathic epilepsy, and symptomatic is if there are symptoms. Sickle cell disease plus generalized tonic-clonic convulsion. What we call it as stroke. Sickle cell disease plus generalized tonic-clonic convulsion. There is stroke. Child presented by focal seizures, including face and upper limbs, and there is neck rigidity. CSF normal, except for increased lymphocytes. Increased lymphocytes means it is viral. So most probably a varicella cause. Child presented with focal seizures, which includes face and upper limb. The child presented with focal seizures, which includes face and upper limb. Child presented with focal seizures, which includes face and upper limb. Then, alhamdulillah, there is neck rigidity, CSF normal, but there's increased lymphocytes. Means definitely it's a viral cause. It is varicella. Head swelling crossing the midline is caput. We should know which crosses the midline and which doesn't cross the midline. So how do you remember caput secunda? Caput. So let's learn the difference between caput succedaneum and cephal hematoma. Actually, caput succedaneum. The mnemonic here is CS. Caput succedaneum means caput succedaneum usually cross suture lines. CS. Caput succedaneum usually cross suture lines. Caput means cap-like swelling. Whereas cephal hematoma is there is collection of blood and it will not cross the suture lines. This is very important. So now let's see the difference. So the difference between caput succedaneum and cephal hematoma is caput succedaneum is a soft tissue edema. It's just a soft tissue edema. And it extends across the suture lines. We can see that it extends across the suture line. This is a soft tissue edema. But whereas the cephal hematoma is collection of blood between the periosteum and the skull. This is the collection of blood between the periosteum and the skull. So it does not cross the suture lines since the periosteum is elevated. But here the periosteum is not elevated. This presents a caput succedaneum is present at birth and it has poorly defined borders. It includes ecchymosis and it disappears in 48 hours. Whereas the cephal hematoma not usually present at birth. It is usually due to traumatic birth injury. It's a traumatic birth injury, increases in size over first day of life and takes few months to resolve, but that will take only 48 hours to resolve. It is usually the edema. Child with URTI developed suddenly ataxia and inability to walk. So URTI before and ataxia and inability to walk. This is acute cerebellar ataxia. Gait abnormalities and it is caused by infections, usually varicella and influenza. Six-year-old child presented with straddling gait and inability to stand or walk without support, with irritability, vomiting, and history of chicken pox. Okay, 6-year-old child with straddling gait, inability to stand or walk without support, with irritability, vomiting, history of chicken pox. This is mainly meningoencephalitis. He has straddling gait, inability to stand or walk without support, with irritability, vomiting, and okay. Marker of the neural tube defect is alpha fetoprotein. Neonate with hydrocephalus. CSF leakage from back. Neonate with hydrocephalus and CSF leakage from back is the Arnold Chiari 2. Neural tube marker is alpha fetoprotein. Neonate with hydrocephalus and CSF leakage from back is Arnold Chiari 2. So the Arnold Chiari malformation type 1, there is downward displacement of cerebellar tonsils. Whereas in type 2, there is downward displacement of cerebellum, brainstem, and the fourth ventricle. Whereas there is downward displacement of the cerebellum, brainstem, and the fourth ventricle. What is Chiari 2 malformation? Chiari 2 malformation is relatively common congenital malformation of posterior fossa where which is almost always associated with myelomeningocele and is characterized by caudal displacement of the cerebellar vermis, brain stem, and the fourth ventricle. cerebellar worm is brainstem and the fourth.